Okay, I think we have some slides. We're off to the races. So. Okay, yeah, so we're, in my time today, I'll just talk about some LVO detection, imaging strategies, and talk a little bit since you are leading the way in a lot of AI technologies. We had the exciting launch of Corindus and the robotics yesterday, and I know that for, again, LVO detection in patients, you use rapid technology, using some AI platforms. So I'll kind of talk a little bit, this comes up, about where we're headed and where some of these technologies have their benefit in stroke triage. So yeah, when we think about imaging in stroke patient evaluation, we ask ourselves the questions: what are the goals? And really, they're fairly simple. I mean, the first goal is basically to rule out, bad stuff, bleeds, stroke mimics, are there tumors, are there, metastatic disease throughout the brain? And then when we get in the category, brain looks relatively good. In other words, it's probably an ischemic stroke. We want to try to find the location of the vessel. Is there a vessel that's occluded? Where is it? How distal, in other words? And then, assess a baseline. What is this damaged area? What is the burden of kind of irreversible damage to the brain versus what is potentially salvageable? Immediately when we talk about imaging, we then kind of launch into, what's the strategy? Do we use our CT? Do we use MRI? We do debate this a lot. I think really there isn't any debate in essence on MRI is the gold standard. Diffusion weighted imaging is the best way to detect stroke volume. Clearly, and it was a very nice talk yesterday. Thank you to our colleague that gave a great talk on his experience with 3 Tesla MRI. I know that you have 3 Tesla MRI to screen stroke patients here at S.I.S. And yeah, that's as good as it gets. I think the challenges are obviously, and this was touched on yesterday, with MRI. Is it available 24/7? I mean, CT scanners in our network, everybody has a CT scanner. That's the tool that is available 24/7 with the technologists that are staffing that. So it's really an availability, access. That's the tool that is out there. Also MRI, there are contraindications. So we have a lot of heart disease. I think maybe even more so, people walking around with all their pacemakers, all the implantable devices, which contraindicate them from going in the magnet. So that's an issue that we can't put 100% of our patients in MRI for evaluation. And then just patient issues. Most patients, obviously, in the middle of a stroke, claustrophobia is not that big a deal, but still, there are patients. We have people that won't fit in the magnet from a body habitus point of view. So CT tends to be the tool, but I'm going to push us back even a little further. We're thinking about this recognition and what platforms we use to evaluate our stroke patients. I'm going to go right back to triage, because the very first thing you have to do is hopefully find our patients in the field. And so when we've done a lot of work in the U.S. in training our EMS providers on how best to try to recognize not only a stroke patient, but now how to basically recognize a patient that could be a stroke patient on the basis of a large vessel occlusion. And, that's not easy for EMS. Basically that training, and we teach them these LVO specific screening tools, and there are a number of them, obviously, as we all know, out there. For the average EMS provider, they see stroke patients or people that have neurosymptomatology, fairly regularly, but for coming across a true positive large vessel occlusion stroke patient, it's probably a 1 in a year experience for them. So, do they have that LVO detection screening right on their fingertips? Probably not. It's hard for them to remember how to identify that patient. So there's been a lot of, again, technologies, app-based things with, our society, S.I.S. We did this app that kind of would allow that EMS provider to basically say, okay, I can't remember all these LVO-specific tools that I was, trained. They have it at their fingertips. They have a number of different tools that they can select from. Just go through, open up the app, walk through the assessment, enter your score, and then at the end it'll say, hey, I think this is a high probability this patient may have an LVO. They need to at least go for screening for that, and that gets them in the right kind of ballpark. Then we move on to kind of AI, so not only just app-based recognition, but how can AI help us? And these AI platforms, as you're using them here, as I said at the beginning, they're not, kind of futuristic, but they're basically, kind of technologies as we jump to warp speed that are presently being used all over the world for recognition. Everybody on the planet is carrying around a smartphone, as we all know. So smartphone technology is in the hands of, obviously, a family member, bystander, if someone collapses with stroke symptoms. So it's great. There's some work that's being done, throughout the world on using that platform and AI to help to recognize a patient. We're familiar with facial recognition and how AI is being used by all the big players, Facebook, Google, to identify different, kind of patterns based on facial recognition disturbances. So this is a CVAID-based platform where basically AI is evaluating the patient. You collect an assessment of the patient, and then AI is analyzing that and doing a stroke scale score, basically, and saying this could be a large vessel occlusion. So there's an EMS provider or nurse at this stage is doing this assessment of the patient. The information and data is beamed to the cloud. AI is analyzing that, and for instance, your facial muscle weakness pattern. Obviously, AI can learn the facial muscle weakness type of disturbances that occur with a stroke patient versus someone that's having a seizure, and so the AI, puts you again into that. Hey, this is highly likely to be a stroke, and then that information is sent back to the stroke team with a digital stroke scale score performed, and the team can make decision making on that basis. So if you kind of look at this, there's like I said, a collector app. You put in some fairly basic patient data, time from onset, what is the main problem. Then you begin this, pointing the camera at the patient, asking them some, simple questions, again, just along the lines of what we would do for a stroke scale score, asking them to do some simple commands like, smile for me, show me your teeth, and then here's an example of collecting. I don't know, you probably can't hear that. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. So again, having the patient, hold their arms up, see if there's weakness, see if there's kind of drift, those type of things. That data, like I said, is then beamed to the cloud, analyzed with AI, and information sent back, and the stroke team gets a notification, and you can view that data to again, see how well it was collected, and the digital stroke scale score is performed, and basically the teams that, hey, this is a high likely patient that has an LVO, bring them to the ER. So once you get to ER, we all know, like I said, the tools and the algorithms that we sort of use in evaluating these patients. We want to do this imaging and decision making pretty quickly. We aim at our institution for a door to picture time of about 10 minutes. So really the path when you hit the ER almost becomes like a portal of entry for registering a patient and just getting them to a scanner for collecting the imaging. Once you get to the scanner, like I said, our shop, is a CT-based shop, and we're going to collect a non-con head CT, CTA, and some perfusion information to again assess those things that we wanted to determine. It's not a bleed. There's a large vessel occlusion, and there's a good mismatch on perfusion for us to treat this patient. We're familiar, I know here you're using Rapid, there's VisAI is one of the other technologies that's out there that's being used in a lot of networks. Dr. Shab has that in his network. And so just speaking to that, I mean, there's kind of an explosion in this, the different software providers that are using and bringing AI technologies into kind of our world. So this is just kind of a list of different companies that are doing that now. Again, we're familiar with these platforms. They really give you a comprehensive package. They're trying to not only assess CTAs, but do automated aspects, ICH detection. So I think their main strength, again, this is the Viz platform. Their main strength is really in an amazing communication way. So in other words, we all know that the way the process used to work is that, someone, say if you're especially in a network hospital, they would get some element of imaging. There'd be a long decision-making process before maybe, hey, this is a stroke that needs to get sent to the tertiary hospital. So a long door in, door out time. A lot of steps, imaging has to happen, radiology has to get notified. It's very time consuming. You get to INR to EVT, a slow door to groin, slow door to needle. So when you put one of these AI platforms in place, it basically rapidly cuts down the time for identification, because at the network hospital, they just scan the patient. Information within minutes is in the hands of the treating team. So you've got almost 2 hours worth of time saving and coming to, yes, this is a patient that needs to get sent. Then there's the analysis when the patient arrives at the mothership hospital, and time savings that occur to decision making. So you overall save hours in the decision making process. And obviously, if we save hours, we know that the patient outcomes will improve based on that. How are they performing? I mean, time savings is important, but it's really more important that they accurately do the job. And AI is, as we all know, a machine can be taught very well to perform a procedure. And so the sensitivity and specificity is very, very high in all these platforms. We do automated aspects, which again, we've had troubles in the past with the human eyes, inter-observer variance, intra-observer variance. We automated on the machine. Again, we see that from these studies that were done, that the automated aspect score were more accurate than experienced clinicians, performing aspect scores. So machines can be taught very well and to do something repetitive. If we look at the ICH software detection, again, very high sensitivity and specificity for their performance. So they're doing very well in the ICH detection. The things that the computer has some problems with is just looking and picking up on the small bleeds. But anybody that's using these technologies, I mean, the rule is still that humans need to get involved. So an overread by a radiologist or whoever's doing decision making is essential. AI shouldn't be relied upon to be the sole decision maker. The decision on the bottom bullet here to treat is very complex and needs to be based on a clinical basis. As we all know, there's a debate, when we get this information, say even about perfusion, there's a lot of ongoing debate in the literature whether what we see on perfusion truly is all dead brain. So even be careful in excluding patients like we talked about yesterday. We don't want to exclude a lot of patients unless we really are sure that they're not a good candidate. So is core really all dead brain is something that is being debated a lot in the literature. The group that's really leading a lot of that is the group from Calgary that have been involved, obviously, in a lot of our stroke trials. They started questioning, whether perfusion is 100% adequate, what we call core. Hey, that's really, really all dead brain. Here were some examples, and I think we've all seen this in our practice. A patient coming in with a right hemispheric syndrome, fairly large stroke scale score. They have good collaterals based on their CTA analysis, and they're fairly, soon from symptom onset. So the CT perfusion information showed a pretty large core infarct. So it's kind of a mismatch. The collaterals look good, the perfusion looks bad. And so they went ahead and said, hey, this perfusion could be misleading or inaccurate. There's a discrepancy here between this information. When we canalize the vessel, you see that on the follow-up DWI, the patient has a very low core infarct burden. So the perfusion was misleading, giving us a big overestimation in the core. So just be careful again. Here's another case, large stroke scale score based on a T occlusion. They do recanalize. Moderately large infarct on diffusion imaging. You might expect the patient is, not going to do that well, but 24 hours later, the patient is almost normal. So that, we saw this very early in our experience. The first patient I treated, their imaging looked horrible, looked like a complete MCA stroke. Patient completely normal clinically within 24 hours. So, there is this whole element of basically, there's islands of preserved tissue within some of the, dead-looking brain we see on CT. So is it really all dead? So, the association between infarct volume and our clinical outcome, generally, the bigger the infarct you have on your imaging, the worse your outcome is going to be. But that is not a complete correlation. It's a moderate correlation in all the studies that we see. There's still patients that have what we would consider on imaging a big infarct burden, but clinically are doing very well. So, so just be careful with that. Imaging is only one facet in the decision-making process. And it's really, as we talked about yesterday, in how you infarct your brain, it's a complex process. It's the same with this. In the decision making, you need to add in multivariables, age, severity of the stroke, what's your premorbid status, time from onset, even the family expectations. If someone is 95 and they're going to be burdened with a big infarct versus someone at 35. And then we talked about collaterals, and a key thing in this core infarct is what part of the brain is actually affected. So that some parts of the brain, as we know, will tolerate an infarct with little symptomatology. Some are very critical. So factor all that in your decision making. I'm still hanging in with my day job. The robots haven't replaced us completely, so it's, they're on their way. But I'll stop, and I wanted to say from our yesterday's experience, we were able to satisfy our durian craving while we were here. So this is Dr. Schaff out on the floating market, and there's our supplier right there. So okay, and then we have the was it good? Here's the analysis and commentary on
okay, what is the it's sweet, it's custody, it's soft.
Okay. Look, they're giving them more. I think he loved it. So we found our homes on the map too. Coom's map. It's got Chattanooga, and Dr. Schaff's originally from Cape Town, South Africa. So we made the map. So It's been great to partner with Kung and the hospital here, see all the great stuff you're doing. So thank you so much for this invitation to be here, and just look forward to a continued experience and continued journey with helping you do great stroke work in this area. Thank you.
Thank you very much, Professor, for your excellent lecture and entertaining. Never amaze us. It will amaze us as a participant. Any question for Prof. Baxter on AI in LVO detection?